Thanks, Claire. Good afternoon, everybody. I fear that I might cover much of the stuff that actually Professor Louise has just covered, but hopefully I'll come at it from a slightly different angle, and it might just solidify some of the key messages that he's already made so eloquently. So what I'm going to talk about is the reframing of public health in the UK coronavirus response. And what I actually mean is not really the UK response, it's the specific response that's been led by England and London, which we're seeing every day through the mass media across the United Kingdom. There is a difference between the English-led response and the Welsh response and the Scotland response and the Northern Ireland response. So I'm mainly talking about this English-led response, if I'm honest, which has been very much talked about as being led by the science. And I've got some key questions about why being led by the science of public health. Why not the art and the science? As Professor Louise has just been pointed out, there's a lot of art within the way that we do public health. And why so little reference to the evidence-based models embraced for the last decade for obesity, smoking, etc. And again, as we've just heard, a lot of those evidence-based models being built upon health promotion. And actually, we're not seeing a lot of that in this public health UK coronavirus response so far. So I mentioned my perspective. I came into all of this in 1984, having done a degree in human ecology, and I've worked, as Claire says, for many years in many aspects of health promotion, community development, HIV prevention, and then latterly as a program director for public health, before stepping out of all of that and doing business consultancy. And I'm currently a PhD researcher, researching what works in community development. So that's the perspective I come at all this from. Solidly as, not an academic, but as a practitioner in health promotion and public health with a fair bit of experience along the way. And to be very clear, what I'm asking is, in this current public health response that we're seeing, particularly in the UK response, why is it so much framed around the science of public health? And actually, is it good science that's actually being portrayed here? What on earth has happened to the art and science of preventing disease, prolonging life, and promoting health through the organised efforts of society? Again, picking up from where Professor Louise ended, whereas the health promotion gone from this whole thing? You know, I'm using a magnifying glass to look at the whole strategy to go, health promotion, the process of enabling people to take control over the conditions that affect their health. Is that what's being portrayed out through this massive approach that's being portrayed through the media day in, day out? Is that about promoting health by enabling, mediating, advocating for people, developing personal skills, creating supportive environments? It doesn't feel that way to me. It feels much more to me, you know, a track back into early 1980s when what we saw was health education around this sort of stuff. We keep hearing being led by the science, but we also keep hearing we've never seen this before. We are reacting in a public health response to coronavirus in the way that we are because we need a massive response, and we've never had to do anything like this before. I beg to differ. I'll accept we haven't seen a coronavirus like this on a pandemic scale like this before, but we have been in a position as countries to having to face something that's new and emergent that we haven't dealt with before. In recent years, we've had in many countries, we've had Ebola and we've had SARS and we've had other coronaviruses. But even in the United Kingdom, we go back to the 1980s, we'd never seen HIV before, and we mobilized a massive national response. And the iconic images that we get from that time are these things around, you know, individualistic, personal responsibility type messages coming out from London, mainly from the seat of power, and messages around AIDS, don't die of ignorance, and lots of iconic images around that. The iceberg image, tombstones on leaflets, and there was an underlying victim blaming within all of this, which was your personal responsibility. Make changes to your lifestyle so that you avoid catching HIV and you avoid getting AIDS and putting a toll on society, etc., etc., etc. And it was alongside other things that were going on at the same time in terms of drug prevention as well. Just Say No campaign, same sort of messages, same sort of mechanisms for getting the messages out to people, largely using mass media, largely doing things like putting a leaflet through somebody's letterbox. Everybody got the same leaflet with this tombstone on the front. Shock horror tactics. Wake up, people, change your behavior. Isn't it interesting that we're coming back now, 30 years later, to exactly the same type of messaging, the same sort of techniques being used? And actually at the time, not everybody was behind all of this. Even Margaret Thatcher wasn't very happy with the whole tone of the way some of this stuff was going. And there were lots of discussions going on in cabinet about, is this the right way to do things or not? So even though we look back at this as an iconic thing at the time, there will be a corporate memory of all of this, that it wasn't the perfect thing, even from those people that were behind the programme. What's really ironic is that at the time that all of this was happening, this massive media-based campaign around HIV prevention, it was totally opposite to the way that people who worked in public health were understanding how we needed to develop health programs. And as Professor Louise has already talked about, some of the major shifts that were already occurring, we hadn't quite got to the understanding around asset-based community development and solution genesis in 1986. We were on the way to that journey. But what we did have was the Ottawa Charter, the absolute grounding of all that stuff around ethics and principles and values around what is it that we need to do to promote health. And we knew then, right at the time that we were running these HIV campaigns, that actually what it meant was connecting with people, connecting health as a value for people, not just telling them what to do to change their behaviour, but actually helping people to get a sense over what they needed to do to take control over the conditions that affected their health. And actually what public health organisations were being asked to do was enable people, mediate with them, advocate for change, strengthen community action, develop personal skills, develop health literacy, create supportive environments, reorientate health services, and build healthy public policy. Not a simplistic thing to do, a major strategic thing to try and bring all these things into play and to shift this balance from it being a professional concern about somebody's health to making it a personal concern, that actually I would be interested in developing my own health. And what did even that mean? Well, actually it meant about just controlling my life, reaching all my goals in life, living life, actually putting life into life. All of these things were what we were discussing within health promotion and public health. And we were facing this major issue, which was HIV. But somehow, despite what happened in all of this, we had this national campaigning stuff that really wasn't hooked into this sort of thought process around health promotion. Instead, what happened when HIV occurred was that at a national level, we went straight back to stuff that had actually come out of the aftermath of the world wars. So we had a health education type that was based around health propaganda, coming up with some really sort of snazzy images and slogans to try and prompt people to change behaviour. And it was based upon this very simplistic model of installing knowledge in people, transferring of knowledge, not really dealing with how people took on board a message, but just simply get a message to people and try and do it in as many different ways as possible. So sometimes using humour, sometimes using shock horror techniques, and aiming to develop a reflexive behaviour in people and communities, often trying to appeal to emotion. Treating people as empty vessels, spoon-feeding the information. And again, as thinking back to today, as Professor Louise has just said again quite eloquently, we put out these messages around face masks and gloves, and it's a simplistic message. We then change the message because we're not consistent with it. People get very, very confused. So we're not really thinking about how these messages are actually received by different sectors of the population. So we've known all this for a long time. We've known that health education in itself is a limited tool. It relies upon a health educator transmitting information to a target group. And it's often characterized by medical practice designing the message, considering that the target group is an empty vessel, and that people will be logical with that information, that somehow we'll all receive that information in the same way, and we will act logically with that information. We're even hearing in the current program, people will use their common sense as if everybody has the same interpretations and will act in the same way with this common sense, totally forgetting that everybody is in their own particular context. I make decisions about my health in the context of my life, and what my other goals are. So I'm not an empty vessel. And often underpinning all of this is a bit of victim blaming as well. You know, if you don't change in this way, it's your fault. And again, hence today, within the messaging around the UK response to coronavirus, we hear things about save the NHS. If you love the NHS, behave and do things in the right way, and you can help save the NHS. And if you don't, if the NHS falls over, whose fault is it? It's yours, not mine. So there's underpinning all these messages some real sense of victim blaming. Now, that's been a little bit negative reflections on what happened with the whole HIV campaign. Of course, we actually did develop some really good health promotion programs, despite that overlying image of it's about tombstones on leaflets and it's about big TV campaigns which are about icebergs. Underneath that, there was stimulated a great range of HIV prevention initiatives, and often because we worked directly with communities. So this is from a gay men's initiative, where gay men were asked about what were the images that, what were the things that they liked in terms of imagery, and things like Bart Simpson, ironically, was one of the characters. So some of the materials that were developed were around images that worked with that particular target audience. In Greater Manchester, there was a charity called Lifeline that worked with the drug using community. And Lifeline worked with a series of cartoonists and people using drugs to work through and understand what the key messages were and how they were heard by the drug using community. And then for drug users to write with a cartoonist their own magazine, their own comic. And it was very explicit. And many people wouldn't particularly approve of the messages that were in there. But for that particular community, the messages worked really well. And Peanut Pete, which is what the comics were based around, this character called Peanut Pete, became very effective about getting a message across to that community. Similarly, in a lot of gay men's communities, the same sorts of things were developed with gay men writing their own leaflets, producing their own videos, doing their own peer-to-peer education, getting messages across to people in a way that had a face validity with them. So what we saw was not just, I mean, I'm using here a variation of Alan Beattie's map of health promotion. What we saw in effective HIV prevention was a mixture of education for health, not just health education, but actually quite structured and well-developed levels of health literacy being developed. So when you're working with the community, asking them to produce their own education leaflets, it's about raising up their understanding and knowledge of the issue in the first place, and then that getting translated into materials for their peers. So developing strong education for health alongside legislative changes, alongside bottom-up community health development, and people for themselves working through issues about health for themselves. So as Professor Louise said, you know, this whole thing over, people actually exploring what health means to them. All of those things need to happen and needed to happen to get effective HIV prevention strategies developed, not simply a health propaganda program in the top left-hand corner of that diagram. So we've known this for a long time. We've known what works in public health programs for a long, long time now. We learned from the HIV campaign, and we learned that propaganda is not enough. And some of that learning informed some of the models that were developed. So we know throughout the 1980s that we've got strong ecological models of public health now. We've got health belief models, stages of change model, social cognitive theory, theory of reasoned action and planned behaviour. And they've followed their way into many health promotion programs. In particular, we've also realised that propaganda failed to work because it was just about broadcast methods. It was a centrally defined method that might have gone out on different channels, but still seemed to work on the basis that you can take a simple message, boil it down into a catchy phrase or whatever, and broadcast one to many. And we know that in the real world, that just doesn't work. Messages are understood by different people in different ways, particularly now in social media. And what happens is, when messages are communicated, they get filtered, they get changed, and they get passed on in different ways. So a communication campaign understands that, and it recognises that once the genie is out the box, the idea is out the box and it goes out, it will be communicated in many ways to many different people, because people themselves will be the channel and will pass it on. And I'll give you an example. I regularly on Facebook get copied into like different games, videos, funny things, information things, and I decide personally the ones that I like and who to send them on to. So if I get football things, they'll get sent on to people like Greg because he likes football. If I get things about music, they'll go mainly to my kids and a few other friends. But I self-select the audience that things go to. And in doing so, I then get sent other things as well. So I'm constantly receiving certain framed sets of information, which a number of people think that I will like. When all of that gets put together, I'll get a whole range of different information, largely because it's been created by the communities that I'm engaged with. This all seems to be being missed at the moment by the current repeat of the propaganda approach that we used in the 1980s. I don't see much of the communication strategy that is being currently espoused within the coronavirus UK approach, taking a communicative approach, multi-strand approach. I see it much more of a broadcast one, even down to simply changing the key messages from stay at home to be alert, whatever that means, and expecting it just to be broadcast. And we all hear those messages in exactly the same way. Again, they think about social distances. Do we all hear social distancing in the same way? I hear it as physical distance, but with social responsibility. Is that what other people hear? I have no idea. So you can't use this broadcast methodology. You've got to think through how you can use a more communicative methodology. And we have lots of programs and models already established in how to do this. This is not rocket science. We've had at least 30 years of developing all of these things. And the government uses these approaches already, or has done in recent years, through its work with the Department of Health, through its work through Public Health England. In particular, we've heard of social marketing, market segmentation, nudge, etc. And specifically, there are these two models that have underpinned a lot of national public health programs in the UK for the last 5 or 10 years. How many times do we have to, hear about the use of the Progesterone di Clemente model to underpin a strategy, recognizing that when we're trying to change behavior, we don't ever go from people not having a behavior to suddenly doing a behavior simply because we've told them to change, or having a behavior and then stopping it because we've told them to change. We know that people go through a whole series of stages. And actually, between each stage, we have different mechanisms to move them to the next level. So if people are in pre-contemplation around an issue, how to move them to contemplation. And then a different set of techniques are then brought in to move them from contemplation to preparation to action, action to maintenance, etc. We know this. We built whole programs around exercise, eating behaviors, stopping smoking, changing alcohol use, etc. We have whole programs built around all of that, alongside another model, which is around motivational segmentation of the population. Recognizing that across our population, we have a percentage of people, roughly a fifth of them, who are health conscious realists, who actually do have that sense of health, and do worry about the behaviours and choices that we make day to day. So if sometimes we drink a little bit too much, or we eat, our diet shifts, or we don't do enough exercise, we then try and balance that out later on. So there are health conscious realists who will probably take on a message about stay at home, be alert, almost more readily. There are some people also that maybe take a few more risks, but are balance compensated, another 17% of the population. But still, you put those two together as groups that are interested in health messages. These are people hungry, waiting for the next health message to do something about all of that. The vast majority of people do not live in those two motivational segments. In particular, the unconfident fatalists. There are people in our society, quite a large number of them, who actually do not have that sense of health at all. Actually feel quite fatalistic about health, that, you know, it's out there, illness is out there, and it's a matter of luck if they get ill, or ill luck. They're unconfident about whether they can actually make any change. And just because we've got this big horror approaching of, oh, there's a virus out there and it's going to get me and I'm going to get ill, doesn't help them feel any more confident about being able to avoid all of that. There are hedonistic immortals who don't particularly feel like that, but are much more into just going at life at full tilt, and are not really seeing the consequences day to day. Don't think there'll be consequences day to day, because actually they're not thinking day to day. Or rather, they are thinking day to day, they're not thinking about long term. So how we take messages as individuals is not uniform. Any one of us will be in one or other of those segments generally, or for particular issues, we may stray into another one. But the point is, we don't all hear a broadcast message in the same way and attach it to our motivations around health. So all these messages around, the messages that are changing, are we going to die if we get coronavirus? Are we going to be poorly? Is it just a bit like flu? What is 2 meters away from somebody? Is that when we're stood still? Can I run past somebody and break that 2 meters? Do I use a face mask? Yes or no? Do I use gloves? Yes or no? Is it young people who get this, or old people? If I catch it, can I catch it again? Can I get it off the post or not? If I just keep washing my hands, is that going to be okay? Do I then still need to use the gloves and the face mask? Etc, etc, etc. That's before we then even changing the big messages like, instead of stay at home, stay alert. And now I can drive to exercise. I can meet with more people, but which more people? So all of those are quite confusing messages as they are, but how they're heard by different segments of the population is very different depending upon which segment you're in. Now, it's not just me that's saying this. Public health programs over the last 5 years in the UK have been using this to target, segment their messaging, and use it through different communication media. Actually using social media to contact hedonistic immortals. Actually doing partnership with people like Lad Bible, you know, to try and get health literacy in the right way to a particularly segmented audience. There are ways and means of doing all of this, of working with each of these segments of the population, but we seem to have forgotten all of that. I'll come back to that in a little while, but what I will say is that despite the fact that we've gone to a health propaganda national approach, this blunderbuss will just give a message out to everybody and forget how they receive it. People themselves have actually done remarkably well in terms of just developing some of their own health promotion anyway. If we think about the 5 ways to well-being, if you're online, if you're connected to other people through networks and through social media, etc., there are some wonderful examples of people using this opportunity within the lockdown of learning, of connecting with other people, of giving, crowdsourcing PPE equipment, funding new food supply chains, being active online, taking notice. Some of the art stuff that's being developed has been stunning if you're online. And of course, you know, the health divide has made that even more difficult. Sorry, the digital health divide has made that even more difficult for people that are isolated and lonely and can't take part in all this. But there are some good movements out there already. They don't seem to be being, though, connected into the UK public health approach. This thing led by the science that's broadcast every day around 5 o'clock. And what we're seeing presented each day is a doctor's view, a nurse's view, and then some charts and a little bit around epidemiology. We're not seeing all these wonderful things about the 5 ways to well-being. They are being picked up in news broadcasts, but not connected with this public health response. So my question is, where is the health promotion public health response? Where is this much more nuanced approach that, please tell me it's going on somewhere. Please tell me that we haven't just forgotten the motivational segment. We haven't just forgotten things like the behavior change cycle, and that actually there's a much more nuanced approach to this public health strategy than is being portrayed each day. And I'm reflecting just on the UK because that's the one that I'm seeing. I do look across and compare with other countries, and it is interesting that criticism is already mounting about the way that the UK is doing this approach, and that we seem to be out of step with, for example, the World Health Organization approach. And I think it is down to us as academics to try and bring out what is the difference between these approaches and bring them to the fore, which is why I'm particularly pleased to be able to take part in this European Public Health event today, because I think we can try to mobilize some of these comparisons. So I've said what's wrong from my perspective, just as an itinerant practitioner. How do we then start to reframe this in a positive way to bring in more of the art and the science? You know, what is the art of public health around a coronavirus? How do we reorientate some of the actions so that we actually start to enable people to take control over their own health? And the key is absolutely in what Professor Louise said right at the end of his session, which was about directly connecting with people, having these debates about what on earth is health all about then? What on earth is life and living all about? We are going to be entering into a new normal. You know, it's going to be a long time, if ever, before this coronavirus goes away and we go back to the way things were. And actually, do we really want to go back to the way things were entirely anyway? Because there was a lot of things wrong with the way that we dealt with the health of people and of the planet in any case. We had never reached that point of salutogenesis with most people, where people really had a value of their health and knew how to control the conditions that affect their health day to day. So there's something about how we need to move forward now, and it has to be about building more of what we already know that works in public health and health promotion and building it into the approach going forward. We have to move this propaganda approach into something which means something a little bit more solid. And how do we do that? Well, one of the ways that we do it is that we start to get front and center some of the other things that are already changing and are solid in local communities. We already do have social prescribing networks. We have health trainers, community connectors, call them what you will. These are people that already know their communities and are having to find different ways of working with them. Why are they not profiled? Why do I see a message from an epidemiologist, a doctor, a nurse, but I haven't yet seen a community connector talking about how their work on the ground is changing with people in communities, particularly those that are not digitally connected? We need to do this rapidly. I was talking last week to a group of health trainers who now are working from home. They're working remotely with people. And I was asking, you know, how's your work changing? And they told me about how their work is changing dramatically, not just in terms of how they're connecting to people over the phone and over video and how that's different from doing it face to face. But they also told me about how people are then relating back to the advice that they give them differently. People that had given up smoking or had changed their eating pattern and now in lockdown have reverted back. They've gone back round that cycle of change. So now the health trainers feel that they're doing even more vital work now, working in a different way with them. This seems to have been forgotten and is out of the public consciousness now about the public health report. We have to bring this front and centre again. Recent existing programmes like the 5-a-day campaign, like Couch to 5K, they are still important. They're still going to be important coming out of all of this. We can't allow the coronavirus response to swamp all the other public health programmes that still need to continue. And there's a danger, of course, that the funding will be switched and we'll forget all of that sort of stuff. We cannot do that. Existing community development, some of it's survived and has taken on a new level, and some of it has just broken down because it just can't work in the same way anymore. So we need to support the existing community development, and stuff that's broken, we need to find new ways of moving that forward. Because often community development is working with those people on the wrong end of the equity scale, and in particular people that are isolated and lonely, and building networks between them. That's absolutely vital moving forward. The digital divide is a huge, huge issue. Despite what I've said about some wonderful things around 5 ways to wellbeing that have erupted in the virtual space, for those people that can't connect to that, what else is happening? What else is happening for those people that can't connect through iPads, phones, computers, etc.? How are we still taking the broader health promotion message to those people? So there's lots of things that we can do. I mean, one of the things that we can do is to develop a new virtual community development approach to engage with social media and virtual platforms. The virtual space and digital media is not a very happy place for health. It isn't just a place that has got these 5 ways to wellbeing flourishing. There's also a lot of dangers in that space as well. There has to be a way that we can take what we know in health promotion, community development, and develop it into a new virtual health promotion, virtual community development approach. At Manchester University, we've got the basis of this in some course units that we're developing at the moment. But it isn't just for us as a university to do this. We've got to bridge the way that we do community development and health promotion and get it into that virtual space. But more than anything else, if there's one message in all of this, it's just that we have to insist that the UK approach gets off from this retrospective health propaganda approach and starts to use the existing evidence of what works in health promotion and public health, in particular using things like market segmentation approaches, what we already know from social marketing, and follow the evidence. We know what an effective public health approach is. It's built upon partnerships and it's built upon co-production. It's built upon this blend of health literacy, healthy public policy, and community empowerment. Health literacy and healthy public policy alone will never change health in communities to the level that it needs to do in a sustainable way without the involvement directly in it of those communities. One, it's wrong to do that, and two, it's just ineffective. We know through that market segmentation work, different communities hear messages in different ways, and we have to connect with those communities to embed health promotion and public health. Who says this? Not just me, not just the Masters in Public Health at Manchester. Within the World Health Organisation's Case for Investing in Public Health, within the King's Fund Improving Public Health series, within local governments, work around return on investment from public health, they all say this simple thing. Effective public health is about blending these approaches together in a coherent approach, which brings top-down and bottom-up approaches together into one systematic way of doing things. And I'm going to leave you with this slide and then take questions or 2 slides. There's something for me in all of this, which is about, even if you've got to put out simplistic messages about behaviour change because this is an urgent thing and you've just got to do something, don't use vague things like be alert. In infection control for a long time, we've taught around simple analogies like breaking the chain of infection. Now, this is not directly related to coronavirus. This is just about general infection, but just simply that model, that analogy of breaking the chain can be so useful, because when you start to think about it, it doesn't matter if you're breaking the chain by wearing gloves or a mask or the distance. The essential thing is about breaking the chain. Once people understand that analogy about breaking the chain, they can start to deal with the issue of the gloves or the mask or whatever. Instead of using that very, very basic principle and analogy and building different ways of talking about that, because I mean, this analogy could be used with young people, with old people. It could be used on all different elements of the program. If you have a central idea about breaking the chain and you hang everything else off from that, it can be flexible. It can be very effective. But it means that once people have got the basic idea in their mind, they can then work through the other bits of this about, do I put on a mask or not put on a mask? Do I wear gloves? Do I wash my hands and all the rest of it? If you understand the chain of infection, you can understand where those things play their part within the whole analogy. And instead, what's happening is, it seems like we're changing our mind about the messages, because we do put out different messages about gloves. Should you be wearing gloves when you go shopping or not? Or should you be washing your hands? Or should you wear a mask or not? And that seems to be changing. People that hear it, that are not involved in medicine or science or epidemiology or whatever, are trying to understand how all that fits together without something to hang it on. Using something like a chain of infection basic message would allow people to work that through for themselves. None of that is rocket science. It's just standard health promotion and public health theory and practice. And unfortunately, I don't see it within the current science-led public health approach in the UK. And of course, the problem with that is that it's not really a public health approach. It's a communication strategy that is being aligned with a public health approach. So, okay, I'll stop there and take any questions. Claire.
Thank you very much. We've probably got time for a couple of questions as we're running slightly over. Just a reminder to people, if they want to ask any questions, to tweet with the hashtag AskPH or email much@manchester.ac.uk, or alternatively, you can leave a comment on YouTube. So the first question, somebody's asked is, do you think health promotion can learn from the ironic situation that more people are exercising now that they have to stay at home?
Absolutely. We need to, it goes back to everything I've been saying really, is that we need to understand how people got to those decisions, what all that was about. Not second guess it, actually ask people. You know, one of the key things about the Prosescu and Di Clemente model is it wasn't a theory that was just dreamt up and then took out. It was built up from looking at practice. What Prosescu and Di Clemente did was they looked at how people had changed and then tried to find if there was a pattern in how people had changed. And what emerged was this cyclical approach. We have to do exactly the same thing with this. We have to learn what the changes were that happened with people and why. What were the triggers? Was it just, you know, that they had more time to do it? What else was it that was going on for people? Don't second guess it. Try and work through with people which groups of people did use the opportunity. Were the people that have not used this opportunity at all? And what was going on for them? Get close to people, get close to their understanding. And then we can find a way of working other programs for the future. Anything else?
There's another one here. So you mentioned be alert and whatever that means. As we live in a quite divided country, there seems to be an association between political persuasion and whether you agree that this message is confusing or not. How difficult do you find health promotion messages during a highly politically charged atmosphere? And how can we cut through the political side to get the best messages out there?
It's a really tricky one because health promotion is entirely political anyway. The whole thing that I've just gone through in terms of the health education which had its heyday in the 1980s, was highly political. That way of developing messages was directly linked to the political viewpoint, which was around developing personal responsibility. There's no irony in the fact that it was Margaret Thatcher who talks about there is no such thing as society, only individuals and families. And the way that we did our health education was on the back of all of that. What flourished, the types of health education that flourished in that time reflected that dominant political ideology. So we just have to be really aware of all of that. And we have to be really aware of the political dimensions to the whole discussion and the framing of the messages at the moment. The Be Alert thing is a really political message. Underpinning the whole thing is about a shift in the responsibility of that. It comes alongside this thing around people must use their common sense. Alongside the Be Alert message, of course, was the other one that came out at the same time, which was around download the app, do your duty. It's your duty to download the app, save the NHS. All of that is political. It's all about who needs to make all the changes to get beyond this pandemic.
Thank you. And I'll just do one final question before we move to Scott, if it can maybe be answered quite quickly. As you mentioned, the common sensing there. You mentioned common sense, and this fits with the intercultural research, which demonstrates that common sense is a cultural concept based on people's values and belief systems. How do we talk about common sense being a cultural concept at the moment without risking a more divisive discourse?
Yeah, tricky. But we have to, don't we? We have to find a way of breaking through. And maybe it is using, I struggle a little bit with that motivational segments thing. But there is something in it about we all hear a message in very, very different ways. We need to try and work through and present the different ways that these messages are being heard. And not bring it down to, it's white van man or whatever that still thinks that they can go out to the pub and, the sneaky lock-ins and all of that. There's got to be a way of stripping that out and getting down to the fact that we hear all this in a different way. We make our decisions in a different way because of all sorts of different stuff. Within community development in what we teach at the university grade, we talk about lay health beliefs, and that's part of it. It's about unpicking where does health fit with all the other beliefs that we have and where did they come from.